I want to thank the ISN, the Kenya Renal Association, the Secretariat, and also want to thank all the members who are here, particularly the adult nephrologists for supporting the Kenyan children and not forgetting them. So today I want to share something small on the hemodialysis of babies. This is our experience. Give me the pointer kindly. Sorry. So for those of us who have not been to Moi Teaching and Referral Hospital, this is a pictorial site where the dialysis unit is hosted here in this particular building. It's called Chandaria Center. This is the only public children hospital. It's called Shoe for Africa Children Hospital. For those of us who love football, this was sponsored by Ronaldo. And it's the only facility. He flies from Europe to Eldoret to see this building. Briefly, maybe to show you, you have the football pitch of the children. You have the class, this is the main kitchen. This is a basketball for the children. These are the classrooms. Because most of our children are chronic and they spend almost a month or so before going home. So we have to continue with their services and their lives. This is our dialysis unit. One of my colleagues, Jesire. I want to share with you members that it's unfortunate today that most of your dialysis centers, you still do hemodialysis, which is our old technology. At Moi Teaching and Referral Hospital, we do hemodifiltration. And I want to recommend all members to go for this hemodifiltration because it's a new technology. Why should the first world be doing and why not Kenyans? So the experience of treating children with end-stage renal disease is not easy, as most of you are aware, largely because it's labor intensive and requires highly qualified staff. They're also including frequent episodes of the catheter malformation and severe infections, among others. And it takes an experience from 1 to 2 years treatment before a child is started on transplant or put on the transplant program. The BD is considered preferred method of renal replacement among the children, but because of sometimes like in our country where the VD catheters, fluids, and also the staffing is a challenge, we are forced to maybe to do hemodialysis, and this has been found to be represent up to 3 to 14% of the patients. And in our center, currently we have got 63 children, which factually is higher than those who are on hemodialysis because we do periodic, only on an emergency basis. Between the year 2016 to 2012, we had 20 infants and another 14 who are less than 3 years. And these are the patients who we look at it. We tunnel them, we dialyze them, and a few have been transplanted. And that's what we want to share. And our study was, we wanted to assess the outcome and the duration of the hospital stay. We also moved in terms of comparison with those several issues on hemodialysis, which are unique in this particular cohort of children. And these are we look at the medical records and we came up with the following results. The duration, the numbers of patients who died during dialysis, the duration of children included the dialysis period and the after transplant period. The percentage of patients who died on renal replacement therapy and the survival and the growth assessed standard deviation among these children. Only those children who were treated with dialysis for more than 3 months were included in this analysis, and additional data were collected for the following: the duration of the stay, the duration of the number of children who were on dialysis, the type of vascular access, and the survival rate of the venous, central venous catheters. Hemodialysis management, we do in referral hemodiafiltration, or rather hemodiafiltration for these children using the Priscilla's machines, Campro machines, and there was maximum extracorporeal volume allowed was 10% of the total blood volume at any point in time. Remember, babies, they have 80 mils per kilo. So in this one, we had to be accurate with their weight so that we know the amount of blood which is going to be at extracorporeal. When the sum of the dialysis and tubing volume exceeded this amount, for example, if the baby is 7 kilos, we brine the blood lines with blood, we dilute it, and if the infant was less than 5 kilos, required priming with red blood cells for more than longer period. And this led to the survival of these babies through the hemodialysis period. We also had it mannitol, largely at the 20th minute, at the 30th minute of dialysis. That's when we started mannitol at 0.5 grams per kilo. And this largely to help this particular cohort of children not to go to this equilibrium syndrome. Those who are on oliguric, remember nutrition also is very important for the children. So you have to balance the fluid overload and their nutrition status. And this is what informed why we chose this particular form of nutrition. And eventually the same thing. It's very difficult to restrict fluid in children because they have to breastfeed, they have to take cow's milk, they have to take fluid. Largely their nutrition is fluid. So really you have to balance. Unfortunately, is that they had to stay in the hospital for longer duration because outside MTRH, most of the counties were not able to do dialysis for these children. The pediatric nephrology had to examine these children at least once weekly, though I have my own Apple team who have happily assisted also on the same. We look at the plasma electrolytes, and we also reviewed parathyroid hormone, among others. Over the last 4 years, the family were also followed by the unit psychologist, the nutritionist, and the entire team to ensure there is a whole team to ensure their care is wholesome. It was caring to the families, particularly to the mothers, because they thought their children would not survive. The dialysis treatment was offered to all children with end-stage renal disease. And most of the babies came because of congenital anomalies, such as Brown-Bailey syndrome, posterior urethral valves, among others. Many families sought advice from the religious authority, relatives prior to making the decision, and minimal duration of dialysis treatment was 2 months. Frequent causes of renal failure was renal dysplasia, hyperplasia was seen among this group of children. We saw a few cases of congenital nephrotic syndrome, I think 5 of them, who eventually went to end-stage renal disease because of the same. Growth also is a real factor because the children have to grow, the height, and this was a real challenge. I want to greatly thank our nutritionists who took their time to ensure these children achieved the required growth, height, and weight. And this was the average increase. Hospital stay, most of these children actually permanent stayed in the hospital. We have had issues with NHIF. Why are these children here? Why are they here the whole year long? My answer was, if somebody comes from Migori, if somebody comes from Turkana, if somebody comes from Mandera, how will they get this dialysis? How will they travel from Mandera to Eldoret twice a week? It's impossible. And that's why we had the children's hospital with the school. And now we are moving forward to have a children's home so that they can be placed in those children's home and they can be coming on the day of dialysis. These were the issues of dialysis duration. Some of them, because of the babies, the nature they had, we had to dialyze 3 times a week or even 4 times in a week. The hospital stay was also longer. The vascular access, we had to put on pump card for these children. I'm sure most of you might find it challenging to put a pump card, but I'll tell you it's just a matter of technique. We just need to watch YouTube, look at it, watch again, assist it, and you have it. I think we are managed out of the 63 children we have, almost 53 of them have a permanent catheters. And my colleagues who are here will agree with me, since we fixed the pump card, we have never had any issues for the last 2 or 3 years. And this is how we did the dialysis, the heparin, and the rest. So blood loss is also an issue, largely because of the lab work. And this is what we did, and we had to time that. But the most important thing is that none of our babies have ever been transfused. Largely, I'll share with you, as Peter Koech shared yesterday, is because of what we put in place. And this is how we are traced. So basically, the blood load was coming to 27 mils per kilo per month. And you'll be able to see this because we're able to address this and fix. Treatment of anemia, yes. Of course, in babies, sometimes we are forced to put IV erythropoietin stimulating agent, unlike the adults where you give subcutaneous. And we also put iron and we minimize the blood loss. So these are the things which I wanted to say. Outcome of infants with dialysis during the neonatal period is poor. Prognosis was significantly better in children who had initiated dialysis after the 3 months of age. Young age initiation dialysis has been previously shown to be significant predictor of the poor outcome with increased risk of death. Outcomes of infants younger than children will undergo was not worse than the peritoneal dialysis as compared to other centers. And ours shows actually the same results as well. So other improvement over the first 5 period was quality of life of the nursing care. We do have dedicated pediatric nursing team who purely their work is to deal with the children, a total of 5 of them. And we hope to expand and to reach every unit in our country so that every child in our country can be reached to. Although yesterday my colleague Muturi said that there are 41 nephrologists. He forgot to mention there are only 5 pediatric nephrologists, and they have remained so for the last 5 years, which is worse for us. So highly experienced nursing team is very important. And this is what I share with you. It's the issue of the hands-on. It's the issue of knowing it. I want to encourage our colleagues in the nursing team to have to spearhead this particular care for the Kenyan children, not only on peritoneal dialysis, but also on hemodialysis and the pediatric transplantation. Other surgical procedures were rare, and the residual volume was key among the children, so that whatever remains, the amount of the nephrons remaining was key. It's our business to ensure those remain. If they were 10, let them remain 10, because they are very key to the growth and achieving the height of these children. Even high experienced nursing term, there was still some drawbacks on hemodialysis. And this need for closer hemodynamic monitoring, especially towards the end of the session, further high blood loss was also need to be reduced on the same. So we corrected that. I also wanted to share with you that we have been able to do a total of 8 kidney transplants for children, and allow me members to share the heroes behind this success. I'll request Dr. Mugalo, Dr. Kasuboy, Dr. Kirwa, Elisha, are you there? Kindly wave to the group. Members, can we clap to them? These are the home ground team. It's by Kenyans, done by Kenyans for Kenyans. And that's where we have reached. At least we are able to do 1 transplant per week. And it's our hope that we shall be able to improve and do succession so that we can get more and more to do for more of our fellow Kenyans. This is our transplant, this is our dialysis unit for children. We do have, in total, we have a total of 28 machines for adults and pediatrics. We are getting more, another 19 more machines for the same. But as I told my colleagues, the work of Kenyatta National Hospital and Moi Teaching and Referral Hospital is not to dialyze, but to do transplant. If I was to give a performance contracts for the 2 or 3 institutions, including KU Hospital, should be based on transplantation, the number of transplant you do per week, not the number of dialysis you do per week. That's the work of the counties. And we are not to compete with the counties because you are given, every year, you are given 14 billion, sorry, to do transplant, but not to do dialysis. Professor, that's a fact. With those few remarks, members, I want to say thank you.